Hello everyone, this is Dr. Shadi. Welcome today to see a new case of touch-up surgery. So, let's see today a new case of dental implants related to our right first and second molar. As we said before, dental implant cases is nothing but it is a replacement of the tooth root with a synthetic material, mainly titanium, to compensate the loss of that root. So later the crown or the prosthetic part will be replaced. We talk here about delayed dental implant placement in case of the prosthetic part will be replaced later. Here we have a pre-operative photograph that had taken to the side. We estimate the buccolingual width. Actually, we can take a CBCT, cone beam computed tomography, radiograph to measure the actual exactly the buccolingual width in addition to height. The height we can take it from the Opg or the panoramic, but also we can see it good in CBCT, and the length, the height, and the buccolingual width. So we advise everyone to use it if he has it. We have to mention something that we have to know also and put in consideration about the difference between height, width, and length of the implant site. So, first of all, the height. The height is the distance measured from the crest of the bone and downward apically, or in another word, it's from coronal to apical point. Whereas the width is the buccolingual measurement, or the distance from the buccal plate to the lingual plate. The length is a mesiodistal dimension, or the distance from the mesial point or side to the distal point or the distal side. So let's take a look on the X-ray. This is a cut of the Opg X-ray. As we see here, the height of the implant site. We have to notice something or know something about we should be always away from the inferior alveolar nerve at least 2 millimeters. Get away from also the inferior alveolar nerve, as we say, 2 millimeters. And here is the length, the mesiodistal dimension. Actually, we can't see here the width, but in CBCT, we can know the width. It's from the buccal to lingual, buccolingually. So always we will talk later, inshallah, about what is the exact measurement that we should know for the for the implant site. As we see here, the incision started. I like to take the incision a little bit lingually, so to get maximum reflection of the buccal and the crystal side without impingement or hiding from the lingual tissue. Hard one-step incision should be taken, and here the goal is to make the reflection easy without a slippage of the periosteum. Also free little bit of the lingual tissue here to make as easy in suturing. Here the photograph. In this picture we can see the width. This is the width buccolingually that we couldn't see that on the X-ray. Maximum exposure should be done, and to make it easily to see the bone and dimension, especially in case if you don't take CBCT, you have to see good by your eyes. We have also to treat the adjacent teeth if they need like a restoration or or any treatment. We have to do that pre or post operatively. In this case, we are going. This is the lower wisdom. We are going to treat it lately. And now we will start with the pilot drill for our points that we are going to make the implant side. Started with the pilot drill. I started here for the 6 or the tooth adjacent to the premolars side, and then also the pilot drill for the other side of implant insertion. And we are going to follow the rules for the burrs that we will use from gradually from the smaller one, bigger and bigger. But before the pilot drill, I take just only the parallel pins to show exactly the direction, so I can know exactly the mesiodistal inclination of the implant. If there is any adjustment I can do. This is the benefit of the parallel pins. As we said, the pilot drill should be on the center, so you can have a buccal and lingual bones in the middle. Try to take the exact direction buccolingually of the burr and mesiodistally. Make your hand stable to not deviate. So take the direction of the adjacent teeth. How the adjacent teeth are inclined, you can take. Then we are starting gradually according to the manufacturer or the company of or the system. Step by step. And after that, there is something very important and I want to mention. This is called the countersink. This is the widening of the apex or of the coronal or the crest or the coronal side or the upper part of the implant side. The countersink drill burr, we use it mainly in the lower jaw. So we widen the upper part only. Maybe we can pass 3-4 millimeters approximately to widen only the upper part, so the implant material or body can go easily. It will be very difficult to go without the countersink burr. This is the photograph taken after the final drill, and we are ready now to put the implants. We can see here also the buccal and lingual plate. We estimate also the direction. Actually, in this picture, I tried to take like a photograph. It will be shown because it's different from side to side when I take the picture. But from here, I can see. If I take it from the other side, it will be the mesial drill will not be shown good. So I think it's just the best shot for the photograph I take from here. Sometimes in other shots, I feel that it's very far from me. After that, we will put the implant material. It's very important to fix the implant in the burr when you start, so it will not fall down. Make sure that it's fixed to the handpiece and reflection. Do not contaminate the burr with any, or the implant with any instruments or tissues. It should be away and not contact the tissue for the sterilization of the site. I start putting the implant by the handpiece until the half or 2/3, then continue with the manually, as we said. This is the cover screw. we will put after final placement of the implant. I want to mention something that we always go down to the bone 1 millimeter to 2 millimeter. So the resorption with bone, if resorbed 1 millimeter, it will be easily to be flushing with the bone later. Don't put it only flushing with the bone. Put it apically 1 millimeter to 2 millimeter. It will be good aesthetically later. And finally, after the implants has inserted, we put the cover screw here. We notice the direction and the buccal and lingual plate. Actually, as I said, the ridge is little bit curved, so the photographs maybe is not that clear for the both of them. I want to mention something regarding to the torque. The torque, if we want to define the torque is how much the force acting on the implant that cause the implant to rotate. So it is expressed or explained by Newton centimeters in cm, and how much. The ideal, it will be from 30 to 40. My opinion, more than 50 or 40, let's say 50, it will squeeze the bone and it will increase the resorption of the bone and decrease the blood supply to the area. Less than 25 or 30, we will not find a good primary stability for sure. And finally, the surgical site has sutured. The suture is the interrupted suture. We have to know that we should not put the sutures under tension. So not too much tension. It will affect the blood supply to the area and the healing process, and not loose. And here finally, the cut from Opg post-operatively to show the implant in place. Thank you very much for your watching. I hope really you enjoy it, and I hope to see you again in touch-up surgery. Dr. Shadi was with you, and have a nice day.